Hello, welcome, and thank you very much for inviting me to talk at this wonderful conference. My name is Maria Hawkins. I'm the chair in radiation oncology at University College London, United Kingdom, and I'm going to talk about the local regional treatment on cholangiocarcinoma with a focus on radiation therapy. My talk will cover the following aspects: an update on radiation technology. Do we know if cholangiocarcinoma is sensitive to radiation? Do we know if local radiation treatment enhances survival? And a quick review of the prospective evidence and ongoing trials. In the last decade, multiple technological advances in radiation therapy have permitted significant improvements in the way we deliver treatment. Stereotactic ablative radiotherapy and hypofractionation, also the use of MRI-guided radiotherapy and particle therapy, in addition to the way we personalize treatment, permit very focused radiation to be delivered with excellent local control. And this is an example of a patient treated with radiotherapy and the results at 6 months. Particle therapy, such as protons and carbon ions, can benefit cholangiocarcinoma patients further. The physical aspects of the treatment will spare the liver parenchyma longer. So on the left-hand side, you have a proton and a carbon ion plan compared with the intensity modulated SBRT plans. Most of the experience in cholangiocarcinoma with radiation is with fractionated radiotherapy and brachytherapy. However, we've now, in the last 15 years, learned that the peripheral intrahepatic cholangiocarcinoma are better suited for SBRT, while the extrahepatic and perihilar hepatic cholangiocarcinoma are better suited for standard or hypofractionated radiotherapy. So, is cholangiocarcinoma sensitive to radiation? So we usually make analogies to pancreatic cancer, and I think we should stop doing that. And when we look at the data we have, we've noticed there's an obvious lack of prospective randomized trials. And a lot of the published data, unfortunately, suffers from poor quality because it's either limited to single institution retrospective reviews or population-based databases. Furthermore, we see a heterogeneity in the patients treated with mixed diseases of different biologies. However, we know that KRAS mutation predict for radiation resistance in multiple clinical models. And this is data for nearly 2 decades ago, looking at colorectal cancer, and really shows that if you have a KRAS mutant cancer, you're likely to be resistant to radiation. This is translated into clinic, and we've noticed, for example, in colorectal cancer, oligometastatic disease treated with SBRT, specifically liver metastasis, patients with a KRAS mutant have worse local and survival compared with wild type. So KRAS mutations predict for radiation resistance. However, cholangiocarcinoma do not have a high frequency of KRAS mutation, especially intrahepatic cholangio, have a KRAS mutation less than 25%. And this is completely different when we compare with pancreatic cancer, where more than 90% of the cancers are KRAS mutant. So we think this is an indication that radiation will likely to be working in KRAS wild type cholangio, but further work we need to do on that. So do we know if local radiation treatment enhance survival? So this is retrospective data looking at population data in patients who are treated with resection and radiotherapy. And what we show that in the beginning of 2000, there seems to be a benefit on the patients who receive radiation in terms of survival. And even now, in the last decade, this benefit seems to have increased. And we can see that nearly 40% of the patients who receive radiation are alive at 2 years. Furthermore, there is evidence in metastatic patients and from the National Cancer Database, when patients were stratified in patients who received just systemic treatment versus patients who receive liver-directed treatment, there seems to be an overall survival with a hazard ratio of 0.57. And you can see patients are alive at 12 and 24 months, and this survival is maintained. However, this is retrospective data, and we don't really know enough about the patient to see who will benefit. So, what is the evidence we have to show that radiotherapy as a local treatment benefits in patients? We know that extrahepatic cholangiocarcinoma has a dominant local regional pattern of failure, and it has a better survival than pancreatic cancer. Furthermore, there is a rationale to maintain local control to preserve biliary function and quality of life. So when radiotherapy is used, we recommend two sequences post-systemic treatment. This is a review of patients who receive stereotactic body radiotherapy. And you can see in various cohorts, the patients' numbers are small with the largest series of 58 patients. But what we can see consistently is that the local control is above 75% at 1 year, as long as the dose delivery is more than 80 gray. There is associated toxicity, specifically to biliary stenosis and GI tract. When you look at the patients who survive, both in 1 and 2 years overall survival, it looks at a group of 30% of patients benefits from this treatment. Um, the fact that the dose is important was highlighted by the retrospective review from MD Anderson and Boston, where 79 patients with inoperable intrahepatic cholangiocarcinoma receive doses of radiation with above 80 gray. And what's interesting, in patients who received doses of 80 gray, the local control was maintained to 75% at more than 2 years, and with a median survival of 30 months. Furthermore, the overall survival was significantly improved, seeing a 3-year overall survival, which was above 70%. There is prospective data from a proton radiation. Again, yellow lines are cholangiocarcinoma, show a local control, excellent at 2 years of 94%, and an overall survival of nearly 50%. We think there is less toxicity than photons. So what about after surgical treatment? We know that more than 50% of patients have local regional failure. And in BILCAP study, we know that patients who had positive margins might not have benefited from chemo. So would the patients with positive margin, are the better patients to receive local regional treatment with radiation after surgery? The only prospective data we have is the SWOG study, which is a single arm phase 2 study, which met its primary endpoint and really shows a 2-year overall survival of more than 60%. And what's interesting, that after local radiotherapy, only 20% of the patients relapse with further local disease. So these are the levels of evidence of currently ongoing radiotherapy trials in cholangiocarcinoma. There is one randomized trial in the perioperative transplant setting, the French Transfield study. There is one a trial in the post-operative study, which is an international effort, ACTIC-RT, and there are 3 studies in the locally advanced setting. One combining radiotherapy with anti-PD-1, a phase 2 study, and a phase 3 study in Tata Memorial looking at chemotherapy versus chemoradiation. This is the overall overview of the ACTICA 1 study incorporating ACTICA-RT, which has been just activated in Germany earlier this month, and patients with R1 resection undergo a further randomization. We are looking to increase the local control from 20% to 45% at 2 years. And the ABC07 study has recruited more than 60% of the patients. And this is a study which looks at locally advanced cholangiocarcinoma and randomizes to cisgem chemotherapy versus SBRT, and looking at an improvement in PFS to 62% from 45% at 9 months from randomization. So in conclusion, the role of radiotherapy is increasing but unproven. We need support to acquire high-level evidence for radiotherapy. The majority of cholangiocarcinoma are KRAS wild type, suggesting perhaps better responsiveness to radiation. And there is data that high-dose radiation can control intrahepatic cholangiocarcinoma. We need to do further work to identify molecular signatures and biomarkers, and identify the patients with a low metastatic potential who would benefit for further ablative treatments. And further work we need to do to learn how to combine and sequence the radiotherapy with a new biological targeted treatments. Thank you.